Welcome and good afternoon, everyone. My name is Polly Joseph. I am an investigator at the National Institute of Health, and we are happy to have you all here for this important conversation between patients, scientists, and clinicians about smell and taste dysfunction. This program is being brought to you by the Association of Chemoreception Sciences, AChemS, and the Smell and Taste Association of North America, STANA. Just a few housekeeping items before we get started. Please use the chat function to ask questions, and we'll try to get to as many questions as we can today. Dr. Leslie Kay will be monitoring the chat and asking questions to the panelists as well. So today we have a very wonderful group panelists. And so without further ado, let me introduce you to our panelists. So we have Ms. Katie Broughton, who is an individual dealing with acquired anosmia. She's originally from the mountain home of Idaho. She currently lives in New Jersey and became an acquired anosmic due to post-viral upper respiratory infection in 2008. She's the founding member and elected president of the Smell and Taste Association of North America since December of 2020, and the creator and producer of the Smell podcast. We are also joined by Ms. Julie Carty, who is an individual dealing with parosmia. Ms. Carty was born and raised in Los Angeles and currently resides in San Diego with her husband and 2 toddlers. Professionally, she has worked in healthcare for over a decade, specializing in helping hospitals improve patient outcomes and experiences. With a master's degree in health regulation and law from UCSD. She has been in several healthcare systems from both sides as a patient and as a patient advocate, and is currently attending UCLA certification program in patient advocacy. We are also joined by Dr. Brad Goldstein, who is a surgeon scientist in the Department of Head and Neck Surgery and Communication Sciences at Duke University. Clinically, he focuses on rhinology and sinus surgery with an interest in olfactory loss. His basic research program is broadly focused on understanding damage and repair in the peripheral olfactory system using cell culture and mouse models, as well as human tissue and single cell techniques. He completed his MD and PhD training at the State University of New York Upstate Medical Center in Syracuse, and residency and fellowship training in otolaryngology, head and neck surgery at Johns Hopkins University in Baltimore. Dr. Goldstein also directs a 7-year otolaryngology research track residency at Duke, and his work is funded by grants from NIDCD at the NIH. We also joined by Dr. Hong Wang, an associate member of the Monell Chemical Sciences Center. Dr. Wang is a basic scientist at Monell, and she grew up in China and came to the US for graduate study and postdoctoral training at Yale University in New Haven, Connecticut. She worked for 3 years as a research scientist at the Feinstein Institute of Medical Research in Long Island, New York, then moved to Monell in 2003 and stayed at Monell ever since. At Monell, her lab studies the mechanisms of chemosensory disorders. They have a research projects investigating both taste and smell losses and taste distortion. Thank you all for joining us today.
So hi, everybody. We are so excited to be here. And in order to get a sense of who's in the room with us today, we actually have a poll question. So the poll question is going to go live in just a moment. And it's basically asking, what's your relationship to taste or smell? So if you could go ahead and fill that out for us, you can click the category that best describes you. And if there is not a category that best describes you, we put in this handy dandy other option for you, so you can click on that. But this will give us a little bit of a sense of who's here in the room, so you can see who's here and we can also see who's here. And today we're super excited to have this conversation with you between clinicians, scientists, and the patients, and we think it's going to be really awesome. So any questions that you have, just to reiterate, please feel free to put those in the chat, and we will try to get to as many of those as we can. We have some pre-prepared questions that we're going to be asking, but we also are going to make sure that we get to some of the questions that you have in the chat. So we'll leave it just a few more seconds to get your vote in. Let me get my timer. And hopefully everyone's doing really well today. So we'll give this just a few more minutes, or sorry, seconds. And all right, hopefully you've had a chance to vote. Let's go ahead and take a look at our results here. So awesome. You can see on the list here who's kind of here. So quite a lot of people with acquired anosmia, like myself. You'll learn more about me in just a little bit. We have a few people who are congenital, lots with parosmia, and so on and so forth, and lots of clinicians, scientists, and researchers, which is really exciting. And thank you to everyone who's joining as a family member or a loved one. That's awesome too. All right, thank you so much. And Polly, I'll go back to you.
Thank you, Katie. So our first question will be for Dr. One. So what got you interested in the world of smell and taste to begin with? And please tell us a bit more about the work you do for the Monell Chemical Senses Center. What does your research focus on? How does it impact people living with smell and taste dysfunction? You're muted, Dr. One.
All right, I just unmuted myself. So thanks, Polly, for inviting me, and thanks for organizing this very interesting and important event. So my journey to the taste and smell field is quite accidental, and because I had a postdoctoral training in immunology, and then I worked for 3 years in a research institute to study the interactions between the nervous system and the immune system. So that opened a door for me to transition into study taste and smell disorders. So my family moved from New York to Philadelphia, and I joined the Monell Center. And as you know, Monell has a very long history studying taste and smell disorders. And at the time, Monell and the Jefferson University has a taste and smell clinic that sees patients and study taste and smell disorders. So it's kind of natural for me to transition into study taste and smell laws, but with a focus on the immune responses and inflammation and the roles of immune responses in taste and smell pathogenesis. So, and I eventually established an independent lab at Monell and focusing on the understanding the mechanisms of taste and smell loss. So the research we do are very detailed analysis, molecular and cellular analysis of most of the time we work on models for taste and smell loss. So we're using, for instance, viral infection models and autoimmune disease models to study taste and smell loss. So yeah, as you know, there are so many various causes for taste and smell disorder. To mention a few, that viral infection is a major cause, which highlighted by the current pandemic. So in addition to viral infections, there allergy, autoimmune disease also contribute to taste and smell loss. And as you know, certain cancer treatment, chemotherapy, radiation therapy also impact taste and smell function. So as well as neurodegenerative diseases. So I think, unfortunately, we still don't know very much about the underlying mechanisms for how these diseases contribute to taste and smell loss. But I truly believe if we do figure this out, the underlying mechanism, we can develop a more specific and targeted therapies for treating these disorders. So I think in that sense, we can impact this community. And in the short term, I think that's a long-term goal, right? So it's therapy won't happen in next month, next year. So it's probably will take 5, 10, even 20 years to develop. But in the short term, I think even understand understanding the mechanisms is important information for patients. So, for instance, we know the taste buds and the olfactory sensory neurons can regenerate relatively fast. So, with the viral targeting these cells, you will expecting patients, people experiencing taste and smell loss due to the COVID-19 may have a rapid recovery. But what we don't know is for a small subset of patients who do develop a long-term loss, and we still know very little about why that happens. So I hope our study will provide some clues to that. So yeah, that's, thank you.
Thank you, Dr. Wong. So the next questions are actually going to be for Dr. Goldstein, and I have a few for you. So I'm going to break them apart to make it a little bit easier. So the first two questions that I want to ask you for the group are, first off, what got you interested in the world of smell and taste to begin with? And then secondly, have you seen, what is the difference between the patients that you saw before COVID-19 and the patients you're seeing now for smell and taste dysfunction after the pandemic? So those two questions.
Yeah, so thanks. So how I got interested in smell loss, I guess when I was thinking about a career in medicine and research, I found my way to a research lab that was studying sort of basic science aspects of regeneration and repair in the inner ear. And that had direct implications for potentially treatments for deafness, hearing loss. And it was just a really exciting time in the field. A lot of new findings were coming out about sort of auditory hair cell regeneration. And it just got me really, really fascinated just by the notion of sort of recovery of sensory function or sensory loss. And so I decided to go to med school and pursue an MD PhD. And then I sort of found my way to working in the lab of someone named Jim Schwob, who was really at the forefront of understanding kind of damage and repair, but in a different place, in the nose. And so we were studying, again, just from a basic science aspect, how things could regenerate in sort of mouse or rat models of damage and repair in the olfactory system, the peripheral olfactory system. And I got hooked, and I've been interested in that ever since. So once I started clinical training and then clinical practice, I became much more interested from the patient side of things. And once I really started seeing and treating people with smell loss, that just sort of is really what drives my current research interests. The fact that we, as we're talking about today, really kind of struggle a bit with having effective treatments for some of these problems. So that really motivates what we do in the lab at this point. And then the second question was what? I can't remember.
Yeah, so the second question that I'm curious about is just sheer differences in numbers between before the pandemic and after. Have you noticed anything?
Well, yeah. I mean, so just generally, like on my clinic days, here at Duke, I see patients with sinus problems, but anyone with smell or smell or taste problems also sort of gets directed my way, and yeah, those numbers certainly increased. I think on a given day I'm probably seeing multiple patients with lingering post-COVID issues with either smell loss, hyposmia, or distortions, parosmia. We certainly still see occasionally patients that are non-COVID, smell and taste patients. So people that have had, for instance, head injuries, blunt head trauma, or non-viral. There are dozens of other viruses other than coronavirus that can damage the olfactory epithelium. Before the pandemic, that was typically most commonly influenza, patients that had delayed or incomplete recovery. So we still see plenty of those, but I'd say the majority are now, unfortunately, COVID related.
Thank you. So my next question for you that I want to ask is, What are the primary treatment options that are currently prescribed for those who present with smell and taste dysfunction? And kind of to tag along with that, is there a set procedure that you're taught at ENT school? Like when someone comes in, you do X, Y, and Z, or is it up to the practitioner?
Yeah, I mean, that's a great question. I can tackle that, and certainly the others can weigh in because I don't have all the answers. Yeah, you know, the taught in ENT school kind of thing, you know, we try to follow what we call evidence-based guidelines. In other words, you know, expert panels, groups, you know, they kind of review the literature. What are the good quality studies that have been done out there, and how can they inform our treatment decisions? In other words, what works, what doesn't work, and, you know, what should we be doing is standard. And in fact, a group called the ARS, the American Rhinologic Society, just published a big consensus. It's like a 300-page paper that's out there. It's open access. It's readily available, and that kind of goes through exactly that process for specifically olfaction. I don't know that there was much in there on taste, unfortunately, but at least olfaction. Those, you know, the take-home message from that document is, I would say our approach is this: we want to evaluate the person, the individual, and confirm a diagnosis as best we can. So, you know, sometimes people come in and they feel that this is related to, prior viral injury or something else that may have triggered this smell loss. But, you know, in our workup, we might occasionally find actually there's something else treatable that's probably the number one factor. And that happens not uncommonly. And an example of that would be, hey, there's actually some inflammation and nasal polyps just in that olfactory region of your nose that, you know, we can actually treat that. We can put you on oral steroids, or we can do sinus surgery, or there's newer medicines like dupilumab or other things that'll treat polyp inflammation. And that can be really, really helpful when we identify something treatable. And so that's a number one thing is try to establish the correct diagnosis. And that's through exam and sometimes imaging and in history. And then treat any identifiable underlying factors. When there's not anything that's readily, you know, treatable, you know, an infection, bacterial sinusitis, inflammation like nasal polyps, you know, then we get into these categories that are a little more challenging to treat. So for instance, a post-viral olfactory disorder, whether that's post-influenza or post-COVID, you know, those we categorize that as sort of what we call a sensory neural loss, as opposed to a conductive or blockage loss. So if air can't make it to where those olfactory nerve endings are, that's a conductive problem. So an example of that would be polyps blocking it. A sensory neural problem would be, well, you know, air makes it right up there. There's really nothing blocking. So the problem is more of a sensory or neural, you know, problem. There's something that has damaged, so say the olfactory neurons, or in some conditions, perhaps it's the central pathways or processing. So an example of that might be, for instance, a neurodegenerative condition like Alzheimer's disease, or potentially trauma. Could be a mixture of peripheral or central problems. But how do we treat those? And that's where we struggle. Right now, olfactory training therapy is often recommended and can be effective in some patients. But really, you know, research is directed at identifying new really effective drugs. So, you know, I know that's a long-winded answer, but that's a complicated question. So, I mean, I'll stop there and let others can certainly weigh in.
Thank you. So kind of to go off of that answer, my final question for you for right now is, for those who are here as congenital anosmics, would your treatment routine change if someone presented with congenital anosmia, or do you think that as an ENT, you would probably go through the same steps for someone with acquired anosmia?
Yeah, I mean, that's another really complicated question. So there's a variety of things that could present with a congenital, you know, or just inborn loss of smell. Generally, the common ones that are well understood, there's a condition called Coleman's syndrome, which is hypogonadotrophic hypogonadism with anosmia. And that's a gene mutation. There's a couple of different genes that have been potentially involved, and it's a little bit heterogeneous. It's not one very specific thing, but it leads to a defect during embryonic development and in the development of the peripheral olfactory system, and specifically the olfactory bulb, and then also a set of neurons that have to kind of migrate up to the hypothalamus that are involved in gonadotrophic hormone secretion. And so that has a very specific thing. One is, when we make that diagnosis, we get a pediatric endocrinologist involved because they can treat with hormone replacement the gonadotrophic hypogonadism. So they'll go through puberty normally if they're put on the right hormones. And that's a huge, very important thing. But we don't have a treatment for the accompanying smell loss, unfortunately. Other congenital anosmias can be sort of, there's other syndromes where, and by syndromic, I mean there's multiple features involved, not just olfactory loss. So for instance, a ciliopathy disorder might involve other organs. There may be kidney problems. There may be, the cognitive deficits. There's other things that other doctors are going to be treating. We don't usually get heavily involved in those patients. They're, those syndromes are somewhat rare, fortunately. But there are isolated congenital anosmias where the only problem is smell loss. And again, there's research looking at identifying what the problems are there with the longer term hopes of potentially gene therapy type treatments where, for sort of a viral vector or some way to deliver the correct version of the gene product that's not working. An example of that, could be a virus that would deliver that therapy right to the nose if the problem is in the peripheral in the olfactory neurons of the olfactory epithelium. People like Jeff Martins down in Gainesville are doing a lot of work that's really, really exciting and on that front. So I think kind of stay tuned as more of those specific mutations or defects are elucidated. I think there will be potentially ways to treat that.
Thank you, Dr. Goldstein. So we're gonna switch gears a little bit and hear from Ms. Julie Carty as one of the individuals who in parosmia. So Julie, can you tell us a little bit about your smell and taste dysfunction story and what inspired you to start the GetSmelt? I hope I pronounced it correctly. And what are your hopes for the future in terms of treatment options from a patient perspective, since you've been dealing with this?
Sure. Well, thanks first off, STANA and AChemS for inviting me to share my story, and of course, all of the research and awareness that you all are doing. So my parosmia is a direct result of COVID. I got COVID when I was 9 months pregnant in December of 2020 on actually Christmas Eve. Thank you very much. And was a very, very fortunate in that my actual experience with COVID was very mild. I had like a very minimal cold. I worked through it. And, but I did notice about a week after of having COVID that I could no longer smell anything. And then my smell loss never came back for a solid 4 months. And I had my baby. I never, unfortunately, was able to even smell my newborn. And it was, those 4 months were extremely depressing. You miss out on a lot of things that smell brings to your life. And I didn't think it could get any worse until from literally one moment to the next, on April 17th, parosmia set in. I was cooking dinner for my family, and all of a sudden, everything that I was cooking and everything that I was smelling and tasting was horrible. The only way I could describe it, because it truly is something that my brain could not process. It's something I had never smelled or tasted before. But if I had to put it into words, it would be chemical mixed with sewage, like hot garbage. And it was horrible. I was completely blindsided by it because it wasn't something I'd ever heard of before on the news talked about. Everyone always talks about, smell loss. And so I think I was prepared for that journey of my smell and taste dysfunction, but I wasn't prepared for sudden, what is that horrible smell and taste, to the point where I thought I was genuinely going crazy. So I put my kids down to bed that night. And of course, like most people, I go to Dr. Google, and that's where my husband and I found that this is something called parosmia. And my parosmia and the severity of my parosmia, I still have it today, but I think the peak and the severity of it, where I couldn't pretty much eat or drink anything. It controlled my life in terms of, I didn't want to leave my home. I didn't want to go to the grocery store because the smells were too strong. I couldn't, brush my teeth that night because the mint as if I was putting in poison, like your body's natural reaction was to vomit it out. And it was horrible. And that lasted for close to 5 months. And that was really, really, really hard. But during that time frame, I was fortunate to find, I live in San Diego, and I got connected with Dr. Carol Gann, that most of you, I believe, know on this call. She has done tremendous work in research and linking smell and taste loss to COVID and continuing to research it. So when I feverishly was like, I need to see you, like her wait list was like in 2 weeks. And I said, I'm not going to make it another day. I need to see someone right now that knows about this. And, I got in with her, she gave me the upsit test. She validated that, first off, I'm not crazy, that this is real. This is actually recognized by the medical community, because my first experience with the medical community was seeing my primary care doctor, who unfortunately, when I saw her, and I love her, she's wonderful, she had no idea what this was. I spent the whole time educating her on what this was. And I kind of left feeling hopeless until I saw Dr. Yan. And so I still deal with parosmia today. It's not nearly what it was. So for that, I am grateful. There's still things that are complete, that like chocolate, peanut butter, anything with mint, anything with citrus, like juices, are horrible. And, I don't know really what's going to set it off. That's the other thing. It's pretty unpredictable. Sometimes I'll bite into something, or I'll take a whiff of something, and it's just that horrible, what we call, I guess, parosmia, the COVID smell. And so that is my experience with parosmia. So I think the second question you had was what then inspired me to start Get Smell. So Get Smell is short for Smell Help. I know it's kind of a weird name. So it's short for Smell Help. And what inspired me, I think, was both my personal experience with it, and also then my professional background in patient advocacy. I spent about the last 12 years working with hospitals on improving outcomes, and how do you engage a patient, and through bundling of products and education to get them to do the right thing and make it easier for them. And so I am a strong believer that everything happens for a reason. So I was trying to make, I guess, lemonade, now horrible tasting lemonade, out of the lemons that I was tasting, and start Get Smelt, because I'm in this Facebook support groups, and I've used them for other mom group things, and I found them to be very helpful. And I see the countless stories over and over again of people having my same experience. Their doctor doesn't know what it is. Their family doesn't understand the severity of it. No one's supportive. And I just felt like, if this was my experience, and this is everyone's experience, and not everyone has a Dr. Gann. I mean, there was a gal in the support group who was locked in a hospital in a psych ward in Italy, because the hospital there did not know what parosmia was. And they were holding her because they thought that she had an eating disorder and was force feeding her. And I just, like, that is just mind blowing to me. And so I had emailed Dr. Hummel, and I said, can someone help this gal? Because no one knows about this in the hospital. So I think between my personal relationship to parosmia and then my professional background was like this, I have to transition, I have to help people. And so that's what inspired me to do Get Smelt. I wanted to give the people the ability to do that upsit test that Dr. Gann gave me, that validated that yes, you have an issue with your smell. I wanted people to be able to have access to that at home, because not everyone has a Dr. Gann, as I mentioned. And then also I think a big part is having, your family and friends navigate this alongside you is very difficult, because it's obviously an invisible disorder. It's hard for people to understand how this has an effect on your life. I mean, Dr. Gann also, I think, did a study where people would literally give up 10 years of their life. They would give up 10 years of their life in order to have normal sense of smell and taste back. I mean, that's how devastating and debilitating this is. And so I really wanted to give people some tools, and their family and friends and their employers some tools to help them navigate this journey, and like things that they could do and change in the things that they can say to help make it a little bit easier. Because I think, as you mentioned, Dr. Wong and Dr. Goldstein, there's no immediate cure, which I think then transitions to your third question. What is my hope for treatment? I mean, obviously a cure immediately, like a pill or surgery that whaps this all complete, but I'm obviously going to be realistic here. And I think as you guys are trying to find those treatment options, I think because this has such an emotional impact on people, I do think that some resources that are readily available from the primary care physician office from the forefront is really important. And maybe having some sort of awareness to primary care physicians and a reach to that subset of physicians, because they're the first line to this. And also some treatment options around mental health for people that specialize in helping people navigate this from a mental health standpoint. And I also think nutrition is obviously hugely affected. I mean, I only drink protein shakes. How healthy is that? That's not healthy. And so having, maybe a nutritionist help someone navigate things and looking at different levels as they are on their, hopeful road to recovery, or until a more readily, available treatment option is available. I think I would like to see some more, efforts being made in those arenas.
Thank you, Julie. And thank you so much for sharing your story. It's very, very powerful. And, as myself, as a family nurse practitioner and a scientist in this space, I see you and I hear you in terms of the need to have more resources for family practitioners and training that can help us. We were really having this conversation at AChemS last week. So really valid hearing more about this from you as a individual going through this is really validating for us clinicians. So thank you so much for sharing that, and we'll hope for the magic pill. We still have to work through this. So just my follow-up questions are for Katie. So we want to hear your story, and we also are interested in really knowing more about what inspired you to start the Smell podcast, and then help co-found the STANA, and what does STANA do for patients and individuals suffering from these disorders?
Absolutely, thank you. So my name is Katie Broughton, and my background with smell dysfunction is that I have had acquired anosmia since late 2008, early 2009. So I'm in my 12th or 13th year already, which is always crazy when I say that. I can't believe that it's been that long. I am fully anosmic, so I don't have a partial sense of smell. I have no sense of smell at all. I am able to perceive things that are due to trigeminal nerve irritation, so things that are very chemically or strong menthol, those types of things, but no other smells. The best guess for why I have anosmia is due to a post-viral upper respiratory infection. When I first became anosmic, it was really scary and really lonely. So I really empathized with everyone who has smell dysfunction and taste dysfunction due to COVID-19, because they're going through that now. And for me, I went through that a long time ago when there was no pandemic and there was no common smell and taste loss symptom of COVID. So it was a really scary time for me. That led me eventually into starting the Smell podcast, which is a podcast where I interview people in the world of taste and smell about taste and smell. I really focus primarily on individuals who are dealing with smell and taste dysfunction so that they can share their story, because I find that it's very powerful to hear from everyone else who's also going through it, so that you know that you're not alone. And that's really why I started the podcast. I'm a podcast nerd since 2008, and I started it in 2018. So a solid decade of listening to podcasts and thinking, oh, it'd be really fun to do one. What would I do it about? And then it kind of clicked one day for me that, oh, how about anosmia and what that's like for people and how it affects their day-to-day life. So if anyone's interested, you can go check that out on anywhere you listen to podcasts. Besides individuals with smell dysfunction, I also speak to researchers, people who are interested. in this space, and really just anyone who has an interest in the area. So I'm originally from Idaho, like Polly said, so not a lot of resources or opportunities to get involved in chemosensory research out there. It's more of a rural state. So when we moved to New Jersey in 2018, I actually got connected with the Monell Chemical Senses Center and went to a conference called Identifying Treatments for Taste and Smell Dysfunction or Disorders, ITTSD, back in 2018. And it was the first day that I ever met anyone else in person who had anosmia. And it was amazing, just to have someone who just inherently understands exactly what you're talking about. No one asked me, but can you smell this? Like, they just knew what I was dealing with. And so getting connected with Monell, getting connected with other individuals, that led to the idea, and that conference proved that there was a need for patient advocacy organizations in the US because there are none, or there were none at the time. So going to the conference, meeting other people, getting connected with Monell led to the Smell and Taste Association of North America. So we're the first nonprofit advocacy organization focused on smell and taste disorders in the United States, and our goal is to branch out into all of North America, so Canada and Mexico as well eventually, but right now our primary focus is the USA. We're a completely volunteer-led organization. Polly Joseph is actually one of our founding board members as well. And so what do? We focus on the need for more conversation and dialogue between clinicians, scientists, patients about smell and taste disorders. How does it impact us on a day-to-day basis? How can we get involved in research opportunities and have our voices heard? Because that's so important, and it's really important to have those dialogues, because researchers are great and they are focusing on the research and they're doing that thing, but I think there's more of a need for us to talk to each other so that maybe we know what to focus our research on, or what do patients need. So that's what STANA does, is we advocate for these things for patients. So if you're interested, it's in the chat. It's the stana.org. You can also check out the smellpodcast.com to learn a little bit more about that. But that is really what our primary focus is. And I'm so excited that we exist now. So check us out. Go to our website and get in touch with us. We'll do our best to find resources for you. And we are a newly formed organization. So we'll continue to grow, continue to advocate, and continue to have these types of conversations. So I'll pass it back over. Hold on one second here. Let me take a look.
To Dr. K.
Yeah, there are a few questions building up in the chat, so I'll go ahead and ask these. And whoever feels like they have information on it, go for it, on the panel. One that has popped up a couple of times, and we do not have any taste dysfunction people on our panel, but any information that we put a link in the chat to the NIDCD website, but is there any information that people can offer based on, about taste dysfunction?
I will start, I guess. We do taste research in the lab, so depend on what specific information you want to look for. There are several clinic taste and smell centers around US, which, for instance, there's one. Monell used to have one, but not at this moment. But so there are one in Connecticut, as far as I know. There are one in Colorado and other places. I don't know if Dr. Goldstein, if your center has provide specific things.
Yeah, I mean, it's hard. There aren't a lot of centers around. I mean, you mentioned most of them, but I think one of the important things to mention is determining whether the loss is truly a taste problem or an olfactory problem. There's a lot of overlap, right? And so our brain, when you're eating, drinking, smelling, your brain is getting a lot of input from different peripheral nerve sites, so one is the taste buds, right? And so obviously sour, sweet, salty, bitter, umami. Those are taste bud signals that are sent to the brain, along with sort of general mouth feel, sort of general sensory information as well. And then there's what's called retronasal olfaction, right? So as you're chewing food, sort of volatile things kind of go up behind the palate and are detected by the olfactory or smell nerves. And so they're sending information as well. So then in our brain, in the cortex of the brain, sort of there's this overall perception of flavor really involves input from all of those modalities. And so when someone has anosmia or smell loss, they almost uniformly say that things don't taste right, because that overall experience of flavor is now missing one of the big inputs, the retronasal olfaction. And in fact, in large studies where people come to a smell and taste clinic complaining of a taste loss, the majority of them, the vast majority of them, actually have an olfactory loss. And so it's actually a bit more rare, quite a bit more rare, to have a pure taste bud or taste loss. That can happen. But so my point is, it's really important to see a doctor that's going to test both taste and smell and determine what the problem really is. So for instance, post-COVID smell and taste loss, it's pretty uncommon to have, and I know Monel's published some things on this, that it's pretty uncommon to have a patient with a lasting pure taste bud damage. The vast majority would have a lasting olfactory damage that's sort of taking its time recovering. But that's a really important thing. So to figure out what it is you're treating, or at least trying to treat. I just want to make that point.
Yeah, there was a question commenting that there was a with taste dysfunction that has been diagnosed as taste dysfunction. Are there treatments? Are there specific centers where taste is itself treated?
Yeah, I mean, so again, I mean, we kind of struggle with restorative or regenerative therapies, of course, whether it's a true taste bud damage or if it's an olfactory damage. I will say that many of the pure taste damage patients I've seen, it's actually, the one treatable thing we come across is patients that have really, really long med lists. Doctors like to give people prescriptions, and as you get older, you see an older patient, maybe in their 70s or 80s, and it's unbelievable how long their med list might be, right? And so, oftentimes some of those people that have reported a taste disturbance, a dysgeusia or an ageusia, we test them and it truly is a taste bud problem. It turns out that they were, maybe put on some medicines recently that are interacting or have side effects that can really cause taste problems. And so we've had some success actually just kind of taking people off of some prescriptions or switching them to something else, in conjunction with their primary doctor, whoever put them on that, and actually solving some of those problems. So that's an important, one of the more common important treatable factors is, we cause it as doctors, right?
I have a couple more questions. There's a question, when the sensory epithelium in the nose, when the smell receptors are sort of killed off, is it possible that it takes a long time for them to grow back?
It is, yeah. So in animal models where we study this sort of thing, the olfactory epithelium in the nose does have a layer of precursor or progenitor or stem cells that truly exist to divide and make new olfactory neurons or nerve cells as needed. But when that happens, that cell has to sort of fully mature or differentiate properly, and then it has to grow its connection back from the nose up through the roof of the nose, called the cruciform plate, to connect to the part of the brain where it normally sends its signals, called the olfactory bulb. And that process takes probably on the order of at least a few weeks, if not longer, to happen. And so for damage to be repaired from this process of neurogenesis, it takes at least a month or more before sort of useful input and, kind of is restored. And so, yeah, it is a long process. Prior to COVID, we had a lot of experience sort of following the natural time course of recovery from conventional post-viral olfactory disorder that caused by, say, influenza virus. And that typically happens on the order of 6 to 12 months. So when an individual comes in and fits, yes, they had a flu test, they were really sick for a few weeks and they kind of got over it and then realized their sense of smell wasn't coming back, and those patients would be followed. It's usually a 6 to 12 month or so process for really recovery to kind of complete or stabilize. And sometimes it's not 100% perfect recovery, but that recovery process does take time.
So this, I think, is for anyone on the panel, just in terms of what you've seen and what you might know. There was a question about whether there was any connection between previous olfactory sensitivity, or people who are very sensitive to odors, and long-term smell loss with COVID. Is there any relationship between that?
I can answer for myself from the patient perspective. And the answer for me is I don't know. At this point, I can't remember what my sense of smell was like before. So that's another issue that we run into, right, as patients, and then probably as scientists and researchers too, is that unfortunately, we don't have a lot of baseline data on what people's senses of smell are like. So when you go to school, you get tested for glasses and you get tested for hearing when you're a newborn, but we don't do that for smell. And so I don't know. So that's something that STANA would like to advocate for in the future as well, is better baseline information on what people's senses of smell are like, because we don't really know. So I don't know if that helps the question, but I don't know if mine was very good before and that's why I don't have it anymore. I don't know, but that's what I'd like to say about that.
So I just want to take this opportunity and follow up for a question for Dr. Goldstein. So that came up. So when new treatments are proposed for treating taste and smell dysfunction, how can patients discern if it's an evidence-based treatment or not? So how can we help patients assess whether what they're being given is appropriate?
That one's to me. So there aren't FDA approved treatment, right? So the one standard for a treatment is it FDA approved? So the Food and Drug Administration, has a very rigorous process that is arguably maybe too slow, but it exists to validate, therapies, drugs, or devices that, provides a level of safety and oversight for patients. So the gold standard, the ideal treatment we want, is an FDA approved treatment that's gone through that process. A lot of things are marketed outside of that, and they'll have a little tiny label on them and type that's too small for most of us to read. This has not been evaluated by the FDA and is not intended to diagnose or treat any condition, right? And it's just sold, and marketed, of course, to diagnose and treat conditions, right? That's sort of the marketing, but it has that little disclaimer on it that hasn't been FDA, evaluated. So, in the absence of FDA validation, then we're left kind of saying, well, what is this off-label or, use for this drug and or medicine or herb, just because something comes from, it's all natural, it's herbal or whatever, right? I mean, that doesn't mean it's still not a drug, it's most of our drugs come from plants and things, right? So, I mean, it's just not been evaluated by the FDA or whatever, but it's still maybe very an active drug product in it,
Dr. Goldstein, can I add a little nuance to this question from the patient perspective?
Sure.
I think that we see, and if someone with an individual with a smell disorder, is we see a lot of things on social media. This is working and that's working, and burn an orange and put some sugar on it and that will cure you. So when we see stuff like that, what would your advice be before I go start burning oranges?
So I'm getting there. I mean, so the first is it FDA approved? Are people, on social media talking about something that's approved or not? The vast majority are not. So then where do we go? You know, and that's a tougher one. I mean, I think talk to your doctor is a good one, right? I mean, your primary care doctor may be able to say, yeah, you know, that's, you know, not an FDA approved thing, but it's really widely used and we recommend it, you know. You know, other than that, I mean, there are websites like, I think it came up in the chat, clinicaltrials.gov. So is this something that's being evaluated in a registered study, you know, potentially, you know, in some rigorous way that's going to answer a question? And, you know, if it is being at least used in that study, you know, you can either talk to the people doing the study if it's convenient or nearby, or there's a site near you, and maybe join the study properly, or at least get some more information about it. There's a lot of information describing the rationale for that use. Failing that, you know, I'd say be careful, you know. There's some good websites. The NIDCD, which is part of the NIH, you know, does have a website that can provide information or links to other, you know, quality websites. But you know, there's a ton of information out there that's, you know, we have to be responsible as individuals and patients, you know, and kind of do our homework, right? I mean, you know, but I would be careful. I would say there's a lot of things that may be either not helpful, if not outright harmful, and certainly potentially expensive. And, you know, I spend a lot of time, you know, when patients come in and say, should I do this or not, and kind of go through what's the level of evidence supporting, you know, any of these things. I mean, there were some harmful things. I'll give you one quick example of harmful things, and there's maybe people on this meeting that were harmed by it, but zinc as a nasal spray. It was a really bad idea. And a company came out with it and called it Zicam, and it actually had active zinc in it as a nasal spray. And if you were unlucky enough to deliver that spray up to the olfactory part of your nose, kind of towards the back of your nose, up really high, called the olfactory cleft, where the olfactory neurons live, there's a wealth of literature going back to the 1940s that we used to, as a scientific community, when we wanted to damage olfactory neurons or kill them in an animal model, like a rat, for instance, we would spray zinc sulfate, and had the makers of Zicam even just like sort of done their diligence and researched, you know, has zinc sulfate ever been sprayed in the nose, they would have found a wealth of literature that, yeah, it's a really common way. If you want to kill olfactory neurons, it's a great way to do it. But instead of doing that, they just came out with this spray, and what happened to people that used it, they killed their olfactory neurons, and many of them never recovered them, you know, because if it did enough damage, it would overwhelm the repair capacity of the olfactory epithelium by wiping out not just the neurons, but the basal stem cells. So there are harmful things out there that are marketed as supposedly helpful. This was supposed to cure the common cold, you know, spray zinc sulfate in your nose and it'll cure your cold. Well, it didn't do that, but it did make a lot of people anosmic.
I kind of have another follow-up question on that, as we're talking, you know, different options for treatment or solutions to try. I see acupuncture being thrown around quite a bit. I'm just curious. I mean, I did acupuncture, and I think that helped me, you know, from an emotional standpoint. Also, you know, what it did to help me, you know, go through my prosme, I'm not 100% sure, but what is the community's thoughts on acupuncture?
So I don't know of specific studies for smell loss that are, you know, well done and reviewed and answering, you know, specific questions, but acupuncture is certainly very powerful, and there's, you know, a lot of conditions that are clearly helped by it. I would say that I'd be interested in seeing, you know, where research on acupuncture for any aspects, as you mentioned, the affective components that accompany similar taste disorders, you know, at a minimum, you know, would be worth looking at. You know, NIH does look into complementary and alternative medicine treatments. I don't know, Polly, if you could speak to that at all, but I think that's a great question.
Yeah, I think that's a great question, Julie. I agree with Dr. Goldstein, like there's really, we don't have the evidence regarding the effectiveness of acupuncture in this area. And, you know, it would probably take looking into the portfolio of that specific institute to see if there has been anything that has been proposed, and also going back to clinicaltrials.gov and see if there's anything there. But that's a great question. So in the interest of time, because we only have 5 minutes left and we want to hear something from all of you. So Dr. K is going to post our last questions and close us off.
All right, so this is a question that will hopefully help interactions for the future. How can patients, scientists, and clinicians best work together to create treatment options for smell and taste dysfunction?
This is for all of you.
Yeah, I'll pipe in very quickly so that everyone has a chance to say something if they'd like to. But in my opinion, in my role as STANA and an individual with smell and taste dysfunction, I would like to be more involved in the research process. I don't know exactly how to go about that, but I think that's why we're having these types of conversations, is how can we get better connected with scientists who are doing the work? And then how can we also get better connected with ENTs who are in training to explain how difficult this can be? So perhaps we work with them to say, my experience when I went through it being diagnosed was that I went through certain steps. So I saw a primary care doctor, an ENT, a neurologist, and then that was kind of it. And that was really hard for me. So how can we perhaps work with those doctors in any field to not feel like we're just alone at the end of that road? And I don't know the answer, but that is what I would like to recommend, is that we somehow work together to make that happen.
I guess I'll just tag along if we're staying in the patient perspective. I think, what is the responsibility of the patient? I think oftentimes people think they don't need to they don't want to go to the doctor because no one knows about it, or there's not a cure. So oftentimes people just don't want to go to the doctor, their primary care. And I think as a patient, I think we need to still go to the doctor because, we need to, maybe there's other reasons that's causing the smell or taste dysfunction. And I think the more exposure that the medical community has to us, the more awareness gets created. And, even if it is educating your doctor, right, they'll know for the next patient. So I think a patient needs to go see the doctor, whether there's a cure or not. And on that token, I think from what do I think could help in the meantime from the medical community is, having more awareness to the primary cares on what this is. So if there's a way to have some more outreach to the primary care groups, I think that would be really helpful.
Yeah.
Okay. Go ahead. I think if from a researcher point of view, I think it would be really helpful to connect research projects with patient pool. So as Dr. Goldstein mentioned, the true taste loss is actually rare. So if we do taste loss studies, so we really need to find these patients. So if there's a centralized website, we can post ongoing research project to help connect with the pool of patients. That would be very helpful.
Yeah, I would just add that you guys touched on medical education, and it's something we're a small specialty, ear, nose, and throat doctors, otolaryngologists. And, we are trying to outreach to our colleagues, and especially in primary care, and get them more informed about what we do, and especially, the importance of smell and taste disorders. I mean, one, upside from this, terrible pandemic is that, people are a lot more aware now, especially my colleagues in primary care, about, these disorders and the people they affect, and who to send people to that have some expertise in it. So, that's a work in progress. I'd make one plug. In the UK, there's a similar patient advocacy group, Fifth Sense, and they've been around for a while. And they've I've talked to them recently. I have some colleagues in UK, otolaryngology colleagues that work closely with them, and trying to troubleshoot some of the exact same problems over in Europe. And the fifth sense is really starting to work with the national health system there, their equivalent of NIH, and really starting to, in an organized way, essentially lobby for research dollars going to smell and taste disorders there. And I think they're doing it in conjunction with some of the otolaryngologists, a person named Carl Philpott, who's really trying to systematically kind of collect the patient perspective and what priorities are important to smell and taste patients that have advocated through that group fifth sense, and in a really organized way try to impact where research dollars are going to address the priorities from patient perspective, not just what we think are the priorities as doctors, but what do the patients want to see prioritized. And I think that's a really powerful and important thing to do. And I think STANA can probably try to join forces and work similarly. Oh, Duncan's on the call. Hey Duncan, how are you? So yeah, he just kind of put something in the chat about that.
Well, thank you everyone for your time, and thank you to our wonderful panelists and all the attendees for taking the time to really have this discussion, which is so needed. As part of these initiatives, we are planning on having more outreach activities for that can continue this conversation. So clinicians, scientists, and patients get engaged, and we can really try to come up with ways to collaborate and move the needle forward in terms of researching this area. So with that, we thank you so much, and we're looking forward to seeing you in the next outreach event.